My name is Susan Misner. I am with the ACLU, and I am joined by Jailer Terry Carl. This is a title that I had not heard before. I assumed it was a sheriff, but in Kentucky, his title is Jailer. And Dr. Nika Jones. Nika is the Executive Director of the Cook County Department of Corrections, and Mr. Carl is the Kenton County, in charge of Kenton County's detention center in Kentucky.
That's correct.
All right. So I want to just warm things up a little bit by asking folks how many people here would regard prisons or jails as the place to provide therapy for people with psychiatric or substance abuse issues. Okay, not too many. You might be happy to know that the public agrees that people with psychiatric disabilities and substance use disorders are better given treatment in the community than incarcerated. And this is one of the tensions that we are facing here, is that a lot of this discussion is about treatment within the jails and prisons, but our goal, I think we would agree, is never to have people be arrested in order to receive treatment.
Yes.
Correct.
So right now, we have huge numbers of people with psychiatric disabilities incarcerated. It is higher than ever before. About 2/3 of people in jails have a psychiatric disability. About half of people in prisons do. And over 80% have some type of substance use disorder. So how did we get here? And I want to just say very quickly that there's a myth out there that we got here because of deinstitutionalization. The closing of psychiatric hospitals in the 60s and 70s is frequently blamed for why we have so many people with psychiatric disabilities on the streets and incarcerated. This is not the major driver. The major driver was that when those psychiatric hospitals were closed, the money that was supposed to move to the community and provide the treatment in the community didn't materialize. Less than 1/3 of the clinics that were planned ever appeared. And even that small baseline has been steadily eroded because of the way that funding occurs for psychiatric treatment in local counties. It's the first thing to go when there are economic downturns. So what is the driver? Well, these numbers started to increase in the 1980s. What happened in the 1980s? Reagan further undercut mental health and other social support services. And probably most importantly, he slashed the federal budget for low-income housing from $26.7 billion a year to $8.3 billion a year. A 2/3 reduction in housing. So I want to put that out there because there are lots of myths that are surrounding why we are where we are. And there are lots of responses according to those myths about what needs to be done. And I just want to say, we don't need more psychiatric institutions. We do need more treatment in the community, and that has to be linked up with the type of stability that housing provides.
Yes.
All right.
Yes.
So let's talk about what you two are doing. Mr. Carl, tell us a little bit about where you saw the problem and how you decided to address it.
Okay, I saw the problem about 8 years ago when the legislators in Kentucky cracked down on prescription drugs. And then when the price of drugs, the pills got so high, they switched to heroin or cocaine or crystal meth, and that's where I started. And the other thing is that, I was, they give me reports daily, and they tell me this individual left jail and overdosed and died. And it got so frequently that, you got to question it. What are we doing wrong, and what are we not doing enough of it? So then that's when we started, thinking, evaluating, and talking to, my case as a judge executive, finding ways to eliminate this problem, not eliminate it, but, cut down on it. And treatment in jails prior to leaving was one of the issues that we looked at.
So you've created a pod where inmates volunteer to participate in 1, 3, 6-month treatment programs, right?
That's correct.
And how's it going?
It's going great. Yeah. And, it's going so good that, our recidivism rate was about 73%. And we also, with the program, we also give the medical assisted treatment before they leave jail. So that's helped. And the program itself probably has a 71% success rate so far.
So measured by recidivism, so
Yes,
about 39% return instead of 75%.
that's correct.
That's great. Dr. Jones,
Yes.
you want to give us an overview of what you've been doing in the Cook County jails?
Sure. So first, let me point out that I think, the two of us being up here is an indication that we are no longer doing business the way that we used to in the criminal justice system. I am a trained clinical psychologist, and some would say I'm the first clinical psychologist to run a jail, and not just any jail, but the largest single-site jail in the country, which is no small feat. And you being a jailer and talking about substance use programming, we have risen to the call to action. And so I started at Cook County in 2006, and at that time we had about 10,000 inmates in our custody, and about 1,000 individuals were being treated for mental illness. And as we began to see the headlines of mental health facilities closing in the city of Chicago, the county of Cook, and the state of Illinois, we started to see our numbers of individuals with mental illness rise. At that time, I was a psychology intern, just trying to complete my doctoral degree. And then fast forward to about 2010, 2011, where our numbers of those being treated for mental illness in the jail doubled. And we were seeing a decrease in our overall population to the point where we are today at an inmate population of 6,000, but we're still treating more than 2,000 individuals with mental illness in our custody. We have more individuals in our custody receiving mental health treatment than what we have state psychiatric beds. And so we said that we knew we had to do more. We couldn't just be the traditional correctional institution, lock them up, hold them, let them go. And so that's when we said we needed to create something different. If you saw that program where the inmates in Cook County Jail were talking about their experiences prior to their involvement in the Mental Health Transition Center, you see why we are very proud of the work that we're doing. We created that Mental Health Transition Center August 1st of 2014 because we wanted to stop that revolving door. People coming to us, individuals with mental illness, it became clockwork that we would expect them to come back at certain times of the year. And I'm not preaching to the choir here. I'm sure we all know. I see many partners in the room that are community advocates, and you understand what I'm talking about. And so we just, developed a mental health treatment program where we offered education, we offered access to housing, which you spoke about, we offered educational resources, and most importantly, we offered vocational skills training to really boost someone's self-esteem and to help them actualize their potential. And that was where we started to see true change. And it wasn't just that, traditional that I think one of the inmates spoke about, where you just put a Band-Aid on the problem, but we really invested in our population, and we wanted them to know that we actually cared. And so we've been very fortunate to have a sheriff to really champion this movement where we're really trying to right the wrongs of our society and say we're not going to do business the way we used to. And we've even taken it a step further, and we offer treatment in the community as well. We're correctional staff offering treatment in the community, and so we've seen great results, and we've been able to reduce our recidivism rate quite significantly.
So I'm going to have lots of questions for you, but if people in the audience have questions as well, there's a way to ask them, and it'll show up on my phone. So the full speaker bios and the opportunity to submit questions and comments is possible by going to kf.cnf.io. So if you kf.c as in cat, n as in Nancy, f as in Frank, .io, and then you can type the link in your phone or tablet and engage in conversation with us. I will try to visit all of the questions that are coming up on the phone, and if you like someone else's questions, that should raise it in the queue. Okay. Everybody got that? Okay. So there's a lot of issues around recidivism, and I want to get to that. But first, tell us more about what you think makes your program so successful within the jails. And I want you to speak a little bit, I've read a little bit about the sense of camaraderie in the pod and the respect and I love the drumming circles and the acknowledgement that one needs joy and support in order to recover as well as treatment. So can you talk a little bit more about that?
Sure. It's important to anyone, not just those that are incarcerated, but to anyone and not just those with mental illness, to realize that you are a part of a larger community and you have a sense of agency. We all have that sense of agency and personal responsibility. And so we started with our staff and helping them to understand their sense of personal agency and being able to commit themselves to doing something positive for the larger community. And we did that through training, and we have ongoing training to do that. And so they come from a place of compassion and love. And when you interact with someone from that standpoint, it's received well. And so that's why I believe our program has been successful, because the inmates that are in the program, and not just the inmates, but their family members that are seeing the changes and hearing the changes, appreciate knowing that Cook County Jail is not what is sometimes portrayed in the news, that there are good people that work there and good people that care, committed to doing what is best for our larger society.
That's revolutionary.
Well, I had the same experience with my employees. At first, they weren't very receptive to it, but after we start a training program and educating them a little bit, then they got very involved in it and actually participate in some of the programs, which is phenomenal. And we also have the peer mentors that watch over everybody, especially the new people coming in the programs. They're watched over and helped and brought through the program.
So are the peer mentors inside, or people who've already gone through the program and are coming back in to provide support?
No, that they went through the program, completed the course, and we keep them in the program.
But not in jail?
Yes, they're in jail.
Oh, they are in jail?
Yeah, all our programs
Okay.
are still in jail. We're just starting to break the ice as far as going outside and working with outside vendor.
Okay. So, Dr. Jones, tell us a little bit more about this transition into the community. and how you're providing support and treatment once they leave the jail.
So we created something that we affectionately call our Discharge Lounge, where individuals being released from our custody, particularly those with identified mental illness, they receive an assessment prior to their departure from the jail, and we link them with services through the help of community partners. So we have a community partner that is there at the point of discharge. They assess our individuals, make sure they're stable to leave. They give them an appointment before they leave, and they follow up with them within 48 hours of release. And, you know, quite phenomenal, we have alumni programs with many of our mental health treatment programs where inmates voluntarily come back to the jail for ongoing treatment services. And so I know that's unheard of for someone to volunteer to go back to the jail for treatment services, but again, we're just trying to fill that void that we know was there in the community. And when we looked at where our population was coming from, we found that they were coming from the parts of the city that did not have as many mental health resources as what was needed. And so we reopened one of the closed clinics that we know was, you know, instrumental in helping us to continue to reduce the number of people coming into our custody. We have, through the support of a family that we helped, they donated a van to our sheriff's office where we provide transportation to individuals, not just to come back to the jail, but to go to appointments, to job interviews, things of that nature. We're really trying to offer more case management and wraparound services for individuals so that they know that there's still a warm person that they can turn to whenever they run into obstacles, which we know obstacles will occur.
And what about the housing?
The housing piece is one that we've been very thankful to our community partners. We've been able to establish permanent housing and some supportive release center support. So we recently partnered with two of the community providers, and they established a supportive release center right off of the area of the jail, where individuals have temporary housing so that they can meet with a case manager in hopes of getting more long-term supportive housing. And we have, again, a number of community partners that help us with the longer term housing.
Great. Okay. So let's talk for a few minutes, and I'm getting lots of questions that I want to ask you. But let's talk for a few minutes about the challenges. What was the hardest part of getting this going? And especially in a red state that's fairly punishment oriented, law and order, pull yourself up by your bootstraps. How did you get this to happen? What were the obstacles you faced?
Well, determination. You know, I grew up in the community, and I was seeing what was happening in the community as far as the overdoses, friends, children overdosing, dying. And I'm just a person that wanted to make a difference. And that was one little thing that I could do. And developing this program, developing the medical assisted treatment, and we also have a reentry program that we try to find housing, and it's all new to us. We're working hard to, we're way behind Cook County.
No, you're not.
And we're trying to develop more housing. We're partnering up with other different agencies in the community.
And how did you find the money at first? And who are your strongest allies and closest partners in doing the work?
Really, finding the money, I found just a little bit of money, $46,000, starting up the program. It was the determination of myself and my staff to make this thing work. And then, of course, the $46,000 didn't even come close to making it, and I absorbed the rest of it in my budget. I had just cut other things out, of course, and we just made it work, and we were determined to make it work. We just did little things to start up, just improved on it little by little, and my biggest supporters was, in my case, like I said, my judge executive in the fiscal court were my biggest supporters, and they didn't even hesitate when I brought it to them, and we
And
developed it from there.
Have you begun to see any cost savings because of the lower recidivism?
Yeah, just a little bit. I think any time you have treatment, for every dollar you spend, you save $4. It's because you're making productive citizens and putting them back into the workforce.
Okay. Dr. Jones, what kinds of challenges and who were your strongest allies?
Well, I think we were challenged, we being the sheriff and I, at the outset, because we were doing and asking our staff to do things that were not traditional in the law enforcement community. And me being a mental health professional coming in, I think there was this certain misgiving that I didn't understand law enforcement. Well, we understood it all too well, and we knew that we needed to reduce the number of people coming in, and the only way to do that would be through programs. And so, we were able to convert correctional officer positions that we had into mental health professional positions and into substance use positions, substance use provider positions. And then we began to see our number of incidents within the jail decrease. And when we got that message out to the staff, then we had more buy-in from our employees. And so when you ask about, savings, there is a cost savings there by reducing the number of people that come into an institution, but also the savings in the protections for staff. A lot of times, you have to put real meaning behind the work, and for correctional and law enforcement agencies, it's making their jobs safer. And so when you look at that coupled with making the lives of those coming into our custody safer, it's invaluable.
So one of the questions we have here is how you engage resistant jail staff.
Do you want to take this
I'm
one?
sure you've never run into that.
Oh, no. It was a challenge at first that, my security staff was used to, strict law and order, and to give individuals special treatment, special care, it was just out of their, they had a hard time accepting that. But after a while, we started training individuals, and it started working. We started making them more part of the program, and that was the key in my situation.
And have they also found that that pod is a safer, easier place to work?
Oh, absolutely it is. Yeah. Very easy to work.
Dr. Jones?
Well, first, I don't pay attention to the blogs.
Yeah. Yeah,
because
that's
if
fair.
I did, I would probably be defeated before I even got started. But, more importantly, we use staff that were committed to helping us in the very beginning to really set the tone. And then once we, again, started to see the decrease in incidents, that was the message that we put out for staff. And some still don't buy in. I don't want to make it seem like life is sweet, but I can tell you that we have more staff now that buy in than those that don't. And one important thing that I learned was always do something for the staff before you do something for someone else. And so we created a meditation lounge for our staff. We bought some recliners that massage and put it in a quiet area of our officers' dining room, and they love it. And they understood that while we were doing things for the inmates, we weren't leaving them behind. And they appreciate those things. They push us to do more. And so we are always mindful that we have to keep our staff first. It's like you can't take care of the child if you don't take care of the parents. Mm-hmm. And so we take care of our staff as best we can. And again, if you have a service that you're trying to initiate for those in your care, it's always good to include the parental figures as well.
Fabulous. I think the massage chair is an idea that I'm going to be taking back to my office. So that was one of the questions, is how you promote the mental health of your correctional staff. Was there anything that you wanted to add to that?
No, we give them special privileges,
For working in the pod?
yes. Is, they get special meals and just little extra things like that.
Okay.
Can I just add that, one thing that I learned, because as a professional working in a correctional institution, it's very taxing.
Yeah.
I'm sure
Yes.
you're pretty stressful days.
Yeah.
And so I was looking for something personal that could help me get through the days. May will be 3 years that I've been in this role, and previous jail directors typically lasted about a year to a year and a half. And so I needed something to kind of recharge my batteries. Well, I ran into this group that provided Transcendental Meditation. And can I tell you, it changed my life. I've become a Transcendental Meditation evangelist. And so I've worked with this group, and we're going to be bringing them into the jail to offer TM, Transcendental Meditation, to our staff. And so it's quite costly. They're helping us with raising funds for it, but that's another, nugget that we've learned along the way is we're learning this as we go, and so what worked for me will inevitably work for the staff, and so we'll hopefully be introducing that soon.
That's great. All right, so I want to get to some of these other questions, but one of them is really how I wanted us to end, which is how do they do this at home? How can other counties replicate this effort? What would you advise?
I would say just do,
Yeah.
We had it in our mindset that we needed to do things differently. We did not know quite what to do. But once we stopped talking and started acting, then we started to see true value behind, the work that we were doing. And so whatever is your profession, whatever is your niche, work at the problem from that perspective and just engage. Whether you're engaging with your local law enforcement community, helping them with training, helping them understand mental illness, whether you're engaged with your neighbor who may have a son or daughter who's incarcerated in a correctional facility, volunteering, those are some of the things that I would suggest that we can do quite easily.
Yeah. Basically, it's the same thing that we start small. You don't have to start off with a large budget. Start small. Keep improving on it. Generate support from the community. We have all the religious groups coming in. We have AA coming in, NA, and different speakers that, motivational speakers that help with the classes and that.
So when we were having some discussion beforehand, it also sounded like there were some pretty logical steps to go through. And I just want to try and encourage us to do those ABCs. And one of the first things you said is just identify the problem, right?
Yes.
How many people in the local jail have mental health or substance use disorders?
Yes.
And what is the screening tool that you use to identify them? Do either of you have a screening tool that you recommend that you think would be useful for other jurisdictions to try?
Yes, we have a 18-question screening as they come into the booking area, and that determines their medical status, if they're on any type of drugs, if they have any physical problems. It works well for us. We're just, our data is getting larger, and by that we evaluate what the needs are of the jail. And it's working well for us.
Great. What about you?
We
Cook
ended
County.
up creating our own assessment tool for individuals coming into our custody because we wanted to really get at more than just the traditional 10-question survey. There are some short surveys that are out there, short screeners like the Brief Jail Mental Health Screener is a popular one. But when you're trying to really make comprehensive changes. What we found is that we wanted to just identify the areas where we wanted to make change, and we started asking those questions. So adding questions about homelessness, adding questions about veteran status, things of those nature, were able to help us better understand the whole person that we had coming into our custody. And there are other substance use questionnaires out there too, like a quick screener is the CAGE. I know a lot of correctional facilities use that.
Great. And then when you're trying to get mental health and substance use professionals to provide support, where did you find the most support? Where did you get the county to actually kick in some resources?
Well, we have a mental health community within our county, and they were very helpful with our mental health issues. They come and evaluate people, and we have a person that just follows them up while they're in the jail.
On a volunteer basis or as part of a public health department?
Just the public health department.
Got it. Okay.
And that works well.
So our on-site mental health services are provided by our county health and hospital system, which is very helpful for us, but then we knew we needed to do more. So to that point, we reached out to some of our community partners, and thankfully Illinois has the Affordable Care Act, and so there were dollars attached to individuals that were leaving our custody, which encouraged community treatment providers to come in because they would be able to follow those individuals post-release. And so we've seen the biggest efforts be made since we've been able to initiate the Affordable Care Act, and we even enroll individuals in expanded Medicaid coverage coming into our jail to help, again, entice community providers to come in and begin treatment services while they're in our custody. So then not only is the individual more likely to follow up with services when they leave, but that community provider is able to get some reimbursements as well.
That's wonderful. And it's one thing that an ACLU report highlighted called Healthcare Not Handcuffs, which that especially in small counties where Medicaid is available, even if it's not expanded Medicaid, many of these people are eligible for traditional Medicaid, the county can save money by shifting people from jail beds, which are usually fully county dollars, to beds or supported housing in the community with treatment because of the reimbursement from Medicaid. So it's a cost saver instead of an extra expense.
Yes.
Yeah.
We just need to pay those treatment providers now, but.
Yes.
Okay, we are running out of time. I want to get to a few more of these questions. One question, it's a little hard for me to follow, but it seems to be trying to ask what the balance is between an approach that is diagnosis and medication focused versus one that's developmental and relational. And I'm wondering how you've struck that balance or which approach you found to be most successful.
Well, for the sheriff's office part, we're not medication oriented. So we have, again, our health and hospital system. They assess individuals. They may deem it necessary to prescribe medications based off of the medical professional's view. But for the sheriff's office mental health services, we're all support-based and it's relational. And so we just provide adjunct mental health services to those that are coming into our custody and trying to reach as many people as we can. So the balance there is leaving the medication and assessment for medication to our mental health and medical providers, and we just do more of the adjunct treatments.
With the support of our hospital, it was easy for us to transition to the medical assisted treatment. And they were very helpful in what bringing us along with that. Plus, we, before anybody leaves the facility, we enroll them in Medicaid. And that's been working very well because we can hand them off to an outside agency and they can continue their medical assisted treatment program, plus the intensive outpatient program.
Fabulous. And there's a question about Narcan. Do you provide that on release? Any access to it?
Yes, matter of fact, we got a grant not too long ago. We issued Narcan to the community, plus we issued to any inmates that would care for it before they left the facility.
Great.
We do as well. We provide the training to inmates in our custody that through our work with the health and hospital system. And then when they're being released, our jail staff will provide them with the nasal Narcan. And we have recently partnered with a community provider so that in that closed mental health clinic that we opened up, we're now training family members and friends as well.
Great. All right, so before the last question, I'm just going to try and summarize for those of you who want to do this at home. You identify the problem, you bring in help from your mental health care and substance use providers in the community. You do preventive reentry work while they're still there, signing them up for Medicaid, hooking them up with services, providing them with a community. And then you've both been measuring this, and that's the last question, is how do you see data sharing as a tool for supporting the transition of care into the community?
Okay, I'm sorry, repeat that question.
Yeah. Someone wanted to know, what is Narcan? Do you want to explain that really quickly first?
Narcan is the overdose reversal drug for opioid. So hopefully protecting people from opioid overdose.
Great. So I think the question about data sharing is really measuring what you're doing, right? How are you measuring your success? How are you advertising that? How do you balance the sort of very cold numbers with the very warm, real stories that we saw in the video at lunchtime?
I can tell you we have an internal research group in the sheriff's office, and they've been studying many of the programs that we provide, and the Mental Health Transition Center program that you saw on the screen over lunch. We've been able to show that a year out, our general population inmates tend to have a recidivism rate at about 51% at 1 year, whereas those that complete our Mental Health Transition Center program and stay engaged with treatment services post-release are at about a 29% recidivism rate. And so to that point also, we have a great sheriff who gets out in the community and he really talks about the stories, and I think that's important, putting a human face to the crisis that we're experiencing. I think we can get caught up in numbers very easily, but when you see stories like what you saw over lunch, it really brings it to home.
We use the University of Kentucky. They collect data for us. We submit all our data right to them. We're now bringing on the Northern Kentucky University. They're also going to be working with us on the data collection. So we'll be able to know where we're at and where we need to go.
Great. All right, so we have been told to wrap up. I want to thank both of our speakers. You're doing fabulous work. It's wonderful to hear about it. And I look forward to hearing about your work as you bring these lessons home and multiply the effect. Thank you.
Thank you.
Appreciate it.
Great.